Hello, and welcome to the George and Fayette Center for Healthcare Innovation, CHI's February Patient Engagement Lunchtime Learning Series for the 2025-2026 academic year. My name is Maxa Sawyer, one of the patient engagement consultants on the patient engagement team at CHI, and I will host the session today. Today's session is Beyond Surveys, Patient and Public Engagement versus Patient-Reported Measurement with Sarah Kirby and Carolyn Shimon. A few housekeeping details before we get started. The PAL series is accredited by the Royal College of Physicians and Surgeons of Canada as a group learning activity. It may also be eligible for credits towards requirements of other professional bodies. We will have auto transcriptions enabled, which can be toggled on or off at any time using the captions button at the bottom of your screen. One of PAL's goals is for the lunchtime learning to be engaging and interactive. Your participation is encouraged throughout and will provide valuable insight and learning opportunities for both the audience and presenters. However, the chat is disabled in this webinar, and we are unable to mute people who are not designated as panelists. Please submit any questions or comments or participation using the Q&A feature located at the bottom of your screen, and either the presenters or I will address them when appropriate. Now I'd like to welcome the speakers, Sarah Kirby and Carolyn Shimon.
Hi, everyone. I'm just going to start by sharing my screen quickly. And I'm going to get confirmation from Carolyn by a nod that you're seeing. Yeah, okay, we're seeing the right part of the screen. So that's great. Thank you for the introduction, Maxa. So I'd just like to start off today by acknowledging that we are gathered on the ancestral and current day lands of the First Nations, Inuit, and Métis people of Manitoba. We respect the spirit, intent, and language of the treaties made on these lands and acknowledge the harms and mistakes of the past and present. As we speak today about interacting with and engaging with patients, it's important to recognize that when true engagement is absent, superficial, or extractive, it can unintentionally reinforce inequities or undermine trust. Meaningful engagement requires relationship, reciprocity, and shared influence. And that spirit is what we aim to reflect in today's session. So I'm going to start by introducing myself. I'm Sarah Kirby. I work at the George and Fayette Center for Healthcare Innovation, along with Carolyn. My portfolio focuses on patient-centered measurement and also providing provincial leadership for Manitoba's learning health system agenda. In the patient-centered measurement portfolio, we're focused on building capacity for the routine collection, analysis, and use of standardized patient-reported measures to support patient-centered care. I'm now going to hand it over to Carolyn.
Hi, my name is Carolyn Shimon, and I am the Provincial Patient and Public Engagement Lead at the George and Fayette Center for Healthcare Innovation and Shared Health. So I lead both the provincial engagement strategy across health systems and health research. And some of my big things are really around the importance of trauma-informed engagement, making sure that our engagement strategies are equity-centered, and that we're really decision-focused engagement is such an important element.
Thanks. Okay, neither of us have any conflicts of interest to disclose. So let's start off with orienting ourselves on why we're here today and why we're having this session. So all of the work that we do day to day really is putting patients first. I mean, that's our primary objective in everything that we do. And so we involve patients in many ways. We involve them through feedback, we communicate with them, hopefully we do some system measurement using their input, and we engage with them. But all these approaches are very different. They have different purposes, they answer different questions, and they carry different implications. And when we blur the lines between them, we can risk limiting our impact, creating a sense of tokenism, and undermining trust. So today's session, we're really going to try to clarify the difference between patient engagement and patient surveys primarily, but also we're going to briefly distinguish both of these from standardized patient-centered measurement. So understanding the differences between those terms, because we use a lot of terms with the word patient in it, but what do we mean by all those terms? So our learning objectives for today, so you should be able to leave the session today able to clearly distinguish between patient and public engagement and patient surveys, and then also understand the difference between patient surveys and patient-centered measurement or patient-reported measurement tools. You should be able to apply a mental checklist that will help you determine whether a patient survey is what you need to inform your service or program, or if engagement is required, or both. You should be able to explain when and where these approaches work together or on their own. And finally, we're going to move away from theory more to practice, where you'll have the chance to analyze realistic scenarios to decide what might be the best tool to use in each scenario. So I'm going to start the entire thing off talking about surveys and about measurement. Starting with the way we typically and conventionally measure health system performance in our healthcare system, just to orient ourselves to all of these different things that we're talking about. So conventionally, health system performance is measured from a clinical or health system perspective. So from a clinical perspective, we ask, like, was the treatment a success? Has the wound healed? Are the laboratory results within the desired range? And then from an administrative perspective, we're often looking at cost. So things like utilization metrics, like number of doctor's visits, number of prescriptions filled, or from an administration or health system side, we're looking a lot often at adverse outcomes, like hospital readmission rates, hospital acquired infection, length of stay. And while all these data are incredibly important and useful to us, they do leave out one important thing, and that is how the healthcare system is performing from the perspective of the patient. So did the treatment achieve the goals I hoped for? Was my healthcare encounter respectful? Can I function optimally at work and in my personal life now? And we tend to collect those measures using standardized tools called patient-reported outcome and patient-reported experience measures, which I'm going to talk to you about a little bit more after this. But we tend to use those tools, and they offer us an opportunity to then link back to administrative and clinical data to give us a more complete picture of how our healthcare system is functioning from the perspective of patients. Now, today we're also going to talk about another tool in there, which are surveys, which is another way that we do get data from patients, but we don't use them for measurement at the health system level for the most part, because they're very program specific and not linked to the patient record typically. So I'll get into that in the next few slides. But just at a broad range, so what is the difference then between these? Because patient-reported measures, like patient-reported outcome and experience measures, they are like a survey. They are surveys. So in what way are they different from patient surveys? Well, let's see why my slides aren't coming up there. Okay, so patient surveys, they tend to be very program specific. So we do these when we want to understand a little bit more about what's going on, how patients are feeling about maybe a change we made, or why we might be seeing some unhappiness with our patient population, or we want to make a change. So we're detecting information from patients. It's very flexible for us, very usually easy to stand these up. But they don't typically involve rigorously validated survey tools like a patient-reported measure. So PROMs and PREMs, patient-reported outcome and experience measures, have undergone a lot of psychometric testing, making them rigorously validated. So they are providing us data that we can use for benchmarking, for tracking over time, and for health system insights. Of course, they also give us data that we can use at the micro level between patient and physician when it comes to outcome measures, at the health service level, so understanding improvement for quality improvement, but also at the system level. And the greater data utility means that because it's connected to the patient record, we can use these data in dashboards with other important clinical data across the system and over time. And even from a research perspective, with the right privacy protections in place, researchers can access and use these data to learn from. So they have that wider data utility. Typically, when we're talking about patient-reported measures, you may have heard of this already. We're talking about patient-reported outcome measures, PROMs, and patient-reported experience measures, PREMs. So many of you have probably heard these acronyms before. They're very similar, except for that they do measure very different things. So starting with PROMs, the focus is on your health status. Often quality of life type things like, are your symptoms improved? Has your pain been managed? Are you able to participate physically, mentally, and emotionally in the way that you want to in your life? Whereas experience measures focus very much on service delivery. So we're asking questions like, were you treated with dignity and respect in the service? Did you leave the hospital, for example, with enough information to manage your care at home? Did the physicians you work with or the doctors communicate effectively with you? So those kinds of very service-oriented questions. We're not asking you about your outcomes, the outcomes of your surgery, or the outcomes of a treatment that you received. So both are rigorously validated tools. They provide information directly from patients, but they aren't measuring the same thing. And I'm going to take a pause here for a minute to just provide an example of all these different data and how they can be used and how helpful they are by using the example of dialysis. So we're trying to measure dialysis from a clinical point of view when you're receiving dialysis, if you've been diagnosed with chronic kidney disease and you need regular dialysis, which is typically 3 times or more a week for 3 to 5 hours at a time, your clinical outcomes are going to improve. We see improved metrics there because you're getting dialysis. It's life-saving. When it comes to health system data, we're looking at things like reduced ED visits, so reduced cost associated with that, reduced hospital utilization. When we look at patient-reported experience measures, we find, the in-center dialysis in Winnipeg has a great reputation. People feel respected. They enjoy it's comfortable. There's a lot of positive experience measures. But when it comes to patient-reported outcome measures, we find that dialysis patients have one of the lowest quality of life scores of many people in the system, including people that are undergoing some very traumatic experiences. And so we need to understand that more. It turns out that people who are receiving in-center dialysis are highly depressed, feel very sort of dissatisfied with their life and are very sort of emotionally unhappy. And so in investigating this more, and this is, we have determined that people would trade years of their life if they could just have dialysis at home. So bottom line is, it's a life-saving a life-saving service. People need it. We're getting great clinical outcomes. But unless we're asking patients, how is this working for them, we sometimes miss really important quality of life metrics. And this has made some larger system changes across Canada, even where a lot more resource is going into looking at home dialysis options for patients. So I just wanted to use that as an example of ways in which ensuring that we're routinely asking patients about their care and how this is applicable in our system. And there's really has been a recognized gap, and this was recognized globally and in Canada most recently in the past 10 years by the Canadian Institute for Health Information, that really this is a huge gap in how we measure our services, and that we're really missing an important piece when we're not routinely asking patients about whether our services are meeting their needs and are achieving the outcomes they want. So I'm just about to pass this on to talk about engagement, but I just quickly want to also talk about the difference between patient satisfaction and patient experience, because a lot of people, I think, come to us looking for satisfaction surveys. They definitely play a role in our system and we use them a lot, but just really understanding the difference between these two things when you're looking to interact with patients. So satisfaction scores are really a very broad construct that is 100% dependent on a person's expectations. So two people with very different expectations will have differing levels of satisfaction with the very same service or the very same experience. So using an example of, say, Carolyn and I going, to stay in the same hotel. Carolyn's been to that hotel. She knows it's a 2-star hotel. I expected it to be a 4-star hotel. When we leave, the hotel gives us a satisfaction survey. Carolyn ranks it as she's pretty satisfied. I mean, this is what she expected. It's all good. I'm giving it a lower satisfaction score because I had higher expectations. Now, the problem with that is that that doesn't always give then the service provider the real clue as to why someone is unsatisfied. And how to improve and where to improve. So with satisfaction scores, it tends to be a little bit more subjective. We tend to use like Likert scales that focus more on opinion, like agree or disagree, where experience scores, we focus more on frequency scales. So we'll ask people, whether they're satisfied, not they're satisfied. We'll ask, did you feel you were treated with dignity and respect? Like never, rarely, sometimes, often, always. So more on a frequency, a spectrum. Now, sometimes expectation is the construct of interest that you're looking at, and in which case you'll use a patient satisfaction score. So they are used in our system, but just wanting to take a moment to show the difference between them and how they tend to be used. So just to cap off this section before we move into engagement, surveys, including patient-reported, like rigorous standardized surveys, are one-directional feedback that we get from patients to us. They give us important information, but different information. Surveys are very practical and flexible for our programs, and we use them often and very valuable in that sense. Whereas patient-reported measures provide us with that rigorous, scalable, benchmarkable data that we can use to inform patient-centered measurements. Okay, I'm going to hand it over to Carolyn to talk now about patient engagement and some of the differences there between patient surveys and engagement.
Thanks so much, Sarah. I always learn so much whenever I hear you talk. So moving over to what is patient engagement? So how we define it is the active, meaningful, and ongoing involvement of patients, families, and communities in shaping decisions about healthcare services, policies, and system design through dialogue, through partnership, through co-design and shared decision making. And the way in which this might work, or the way in which you see this oftentimes in health systems, is having patient and family partners or communities integrated onto governance level structures. So thinking about having folks on steering committees and working groups and quality circles and implementation teams. So actively involved at the table in the co-design. You might also see the establishment of an advisory group, a patient and family advisory group that might be informing forming a larger provincial clinical service strategy around, say, palliative care. And so there might be a multitude of projects and initiatives, and they'll help that there's enough for an ongoing advisory group to help inform those decisions. And then another way that you might see it is for a specific program or initiative, it might be a co-design workshop. So bringing folks together and helping inform the development of a new program or initiative. And maybe if we can switch to the next one. So it's really important to understand what engagement is and what it isn't. When we talk about patient and public engagement, we're really talking about relationship. So engagement is not just asking a question, it's entering into a conversation, it's dialogic, meaning there's a back and forth, there's listening, there's reflection, there's sometimes tension and mutual learning. And a lot of times you'll hear both parties maybe change by the interaction, right? So you may have health system folks and clinicians go, wow, I didn't think about it from that perspective. And you'll also have patient and family partners as you start getting into dialogue saying, oh, I didn't understand that system piece. And so it's really about that back and forth conversation. But engagement really requires time, and it requires trust and transparency and clarity. So having a feedback loop about how the input actually informs the decision. So you're going back and letting folks know this is how your input affected this decision or didn't affect this decision, and this is and why it's so. So really explaining and being clear on how input was being used to inform decisions. And so a way of looking at it, so some examples of where patient and family partners may inform decisions includes in clinical service planning, a lot of times patient and family partners help inform upstream decision making. So they'll help inform the development of new care pathways or models of care. They'll really help inform processes around access, eligibility, and referral. They may inform the implementation of a new project, so some of the patient-facing elements of the implementation. And they'll also when they're engaged in interpretation of data, they might identify equity gaps or things that might not necessarily, when you're working within the system, you might not necessarily see. For quality improvement, it's really about helping determine what is worth. So it's really a lot of times folks can actually help you prioritize what are important improvement initiatives. They'll help you define meaningful outcomes. They'll help co-design workflow. They'll help identify where there might be some root causes of systems problems, and they'll help interpret the data and evaluate impact. So they'll really help inform those processes as well. And as you can see, clinical service planning is really about influencing the architecture of care. And then when we think about quality improvement, they can help in the interpretation and the co-development of solutions and ways to move forward. And then for patient safety, patient partners oftentimes can identify safety risks that we might not necessarily see from within the system. They can help co-design reporting processes and disclosure practices. They might also help inform policy and protocol reviews, designing safer transitions to care, and even what we can learn from harmful events, not just from a procedural perspective, but also from a relational perspective. And so it's really important to think about what measurement is and is not. So I guess this is what Sarah, you were talking about before, that it's structured and standardized tools and it's scalable and comparable and essential for accountability and monitoring, but it's not engagement as far as co-design, shared decision making, giving context to the interpretation of the data. And it's not a substitute for that dialogue, that back and forth engagement that's going on. So, in summary, a survey really helps ask patients what happened, and engagement really invites them to shape what happens next. And so, with patient surveys, we're asking questions and we're extracting information, and it's a one-way dialogue, it's episodic. There's data collection and it's transactional. In patient engagement, it's really about sharing decision-making power. So it's about building trust and relationships and partnerships with people with lived and living experience. There's a two-way dialogue going on. Oftentimes it's an ongoing process, and that there's active co-design and shared decision-making going on, and it's very much relational. So sometimes some of the best questions you can ask yourself when you're thinking about, okay, do I want to do patient engagement? Do I want to do a survey? It's really to think about, do we need depth or do we need breadth? Are we shaping decisions or are we tracking outcomes? Is context needed to interpret the results that we're doing? Or that we're seeing, are decisions already made? So these are really good ways to think about it. So when we talk about whether we need depth or breadth, so for depth, we're really wanting to engage folks. Breadth, we want a larger amount. So we might be doing surveys. Are we shaping decisions? Well, that would be engagement. Tracking outcomes, that would be measurement. Is context needed to interpret the results? Of course, you want to engage folks in the interpretation of results. If decisions are already made, then it wouldn't be considered engagement. So engagement really exists when patient and the public inform what questions are going to be asked, what outcomes are prioritized, how services are designed and implemented, how resources are allocated, and how findings are interpreted. And we really want to think about how engagement is not representative sampling, because this can often be misunderstood. Engagement's not about statistical representativeness. That's, of course, the logic of research and surveys. Engagement's really about experiential knowledge and lived expertise. So we're not trying to generalize to a population, but rather representation when we talk about engagement is around diversity and inclusivity. So you want a diverse group of perspectives at the table to help inform decision making. And just like clinicians and health systems decision makers bring different perspectives to the table, of course, we want people with lived and living experience to also have the opportunity to bring that experiential knowledge to the table as well. So if you're calculating sample size, you're probably not designing engagement, you're designing research. That's always a good way to think about it. And so engagement really helps us decide what matters. So if you look at it, so you may have a cycle where, first of all, you engage patient and family partners in identifying priorities and defining what matters most. But then you might do a survey to explore or detect signals. You might decide to do some measurement by tracking experiences and outcomes. Then you might re-engage people with lived and living experience to interpret those results and then think about how to co-design a solution. And then again, you can use measurement to assess impact over time.
Okay, Carolyn, I think that ends that till puts us into the scenario section. And I
Ooh.
realized that I forgot to pause after my to just check in to see if there were questions. So maybe before we jump into scenarios, Maxa, do you want to let us know if there are any questions at this point?
Sure, we have two questions. Um, One of them is, how do you create a patient measurement survey? Are there specific questions that have been validated that are used, or can we create questions specific to our program that use a frequency scale?
Right, great question. And that one does come up quite frequently. So typically people don't create their own standardized tool. There are hundreds upon hundreds of already very well validated and rigorously tested tools out there when it comes to either experience or outcome measures. The validation process is a long and rigorous one. The Center for Healthcare Innovation has people that undergo these on a regular basis. So typically, that's what you would do, is that you would use an already developed standardized tool. So let's use a couple examples, because we do this a lot in our own healthcare system already. So in hip and knee surgery, hip and knee replacement surgery, we've been collecting a standardized patient-reported outcome measure for the better part of 15 years. It's the same measure that hip and knee replacement surgery suites across the country use the same measure, and now across the world. We're organized with the OECD. This gives us incredible data, not only for the surgeons to, first of all, guide the decision making with the patient at that micro level, but it gives them huge amounts of operational data that can be comparable to other services across the country and across the world, because they're using one standardized measure. And so when you're in a field, like another example is cardiac rehab, which we're going to get into in the next scenario, spine surgery, cancer care, they're not interested in making their own standardized survey, because their programs all around chronic kidney disease across Canada and the world that are using really rigorously validated tools, and those are the tools that you want to use. When it comes to experience measures, there's less of those tools around, and so we do have a few validated questions that we can put together to make a more standardized tool that's maybe just more for us in Manitoba. So that would be true for experience surveys. So that's a yes/no question. So typically we wouldn't do that, but when it comes to patient experience measures, we can do that. We can use some standardized questions to put together a more standardized survey. And was there a second part to that question, Max, that I forgot? I think that was pretty much it. You're muted still.
Sorry, I think that was good. We also have a question about engagement, Carolyn, asking how do we translate engagement data, which is experiential and nuanced, to research data that can help inform policy decisions?
Right. So I think one of the big things is, and it's interesting, we did a talk, our January PAL was a little bit about experiential knowledge versus lived and living experience. And so if you're engaging folks around a decision, say in research, you really want to make sure that the way in which you frame your question, so when you're asking patients and family partners, say, for example, I'm trying to think around outcome measures that are important to include in your longitudinal study or something, or things that are really important and matter and value to them. It's really important to phrase your question in a way that ask your patient and family partners uh, for them to reflect on their experience, on their lived and living experience, but then to be able to give you advice to inform the actual decision of your research process. And so there's a way of doing that, and definitely we've got that video from the January one up that we can always send out for you as well. That kind of gets into how to engage with folks in a way that they can meaningfully contribute to research decision making. And so I think that was, sorry, I'm just going to double check. How do we translate engagement data, which is experiential knowledge? Yeah, so a lot of that is just the way in which you lay out your relationship and the way you develop your and design your engagement strategy. So, and that you're asking questions that will actually help people with lived and living experience not only tap into their lived and living experience, but to translate that into experiential knowledge that will then help inform your decision along the way. I hope that helped answer.
Thank you. I also have a question that was just emailed to me. But before that, I just want to acknowledge a comment that says a lot of these words are incredibly close to each other in meaning and very easy to be mistaken for each other. This video will be uploaded to YouTube, and we will provide the link when it is available. And there's a question about slides. We usually do provide the slides. Um, a question that was emailed to me is anti-race is if anti-racism has been incorporated into patient experience measures or surveys, or if anti-racism is being explored in any way in those patient experience measures or surveys.
That's a great question. So we worked really closely with our provincial race, ethnicity, indigenous identity data team that's working on collecting that data, and there's some really rigorous provincial governance around that. So we've in fact removed any questions related to REI from the survey. Typically, it would be included in there so that we can do different analysis with the data to see, are people with different ethnicities or different indigenous identities having different experiences at different points of care. And because we do right now have one prem that we use in our system, the Canadian Patient Experience Survey in patient care. And so we've removed those questions so that when we decide to explore those issues, that we would do that following the provincial governance process for that, and involve the community in that decision, like how we would do that and what we would want to look at, and then what we would do with those results, like how we would act on those results. And there's definitely an interest. There is definitely an interest in doing that from those teams and from a provincial level. So I think that answers that question. And I will add to when Maxa sends things out, I agree. And that's why we're having this session, that we just stick patient on everything. Of course we do, because like I started this presentation off, everything we do is patient-centered. And sometimes I think when we're saying that we're being patient-centered, we think we're engaging patients somehow, but there are subtle differences that are important to remember. And we have developed at CHI a very short learning module that has the intention of helping people understand what we mean by patient-centered measurement versus patient surveys and focus groups, and getting information from patients and learning from patients in that way. What the subtle difference is, yes, sure, there's definitely overlap, but we are using these tools in slightly different ways, and it's an interactive way of maybe helping to solidify those. And we can send that link out if people want to take a look at that. It's very short and quick and interactive.
And then we have one more question, but I think that will be good for the end of the presentation. So I think it's good to move on.
Sure. Okay. So I'm going to run through the first scenario here and what we're going to do. And I think this could be challenging because I guess because we're not really interacting that much with the audience, and I can't even see anybody because I'm managing the slides right now. I'm not sure if you can just add your responses into the Q&As if you want, or just sort of think this through. But here's a scenario that comes to us sometimes. So let's just, it hasn't come from cardiac rehab, but let's just pretend that we have the cardiac rehab program coming to us saying, we want to improve our program. We need to engage patients. Can the patient engagement team help us run a survey? So when you're, thinking about ways of interacting with patients or what you might need, we always start with, what is the purpose? Like, what are you trying to achieve here? Do you want to just detect a signal from patients and decide what may be working versus what's not working, in which case, you're right, you may want to run a survey. That you wouldn't come to the patient engagement team to run a survey because they don't typically run surveys, because as you just heard from Carolyn, that's not one of the ways of engaging with patients and family and people with lived experience. You could come to my portfolio, you could come to the evaluation portfolio, you could look at other surveys that have been run, from other similar programs, just looking to glean information from patients. But maybe what you want to do is you want patients to help you design a whole new program, or to really be involved in like a complete redesign process, in which case you're going to want to have a fulsome engagement with patients, and you may need some advice and tools from Carolyn and her team. What are some other purposes here that we might? I know I did highlight to Carolyn that there are scenarios here where you may want to measure change over time. And I know cardiac rehab program in Winnipeg and definitely Southern Health and maybe other regions do collect standardized and routinely collect patient-reported outcome measures, because that's really important to them. They're delivering a program that is supposed to improve your quality of life. And so they need to be asking patients routinely whether that quality of life is being improved, and whether those services are having the outcomes that the patient wants to have. Again, a little bit different than engagement here. You are engaging in the fact that you're asking patients for feedback, not quite the same thing. So I think what we wanted to really emphasize here is just recognizing that broadly asking patients for their input, whether it's through a survey or a standardized tool like a PROM, it doesn't necessarily equate to engaging patients. So volume doesn't necessarily equate to ensuring that you have, diverse engagement. And I think Carolyn's going to get into that a little bit in some other scenarios.
And I was even thinking, Sarah, with the cardiac one, if they went the route of doing a survey, you could also have people with lived and living experience involved in the interpretation of what the findings are from the survey, and then at thinking about how are we going to co-design a solution afterwards and implement change.
That's a great addition. And that would be true too of those standardized surveys that they currently do run. When they look at their data, if they find out, you know what, it turns out that most of our patients aren't managing their pain well, and they want to understand a little bit more why aren't patients managing their pain well after they run through our rehab program, that would be a time to do some further engagement with the people who are accessing and utilizing the program.
Yeah, it's amazing sometimes when it comes to interpretation of the data, how much having folks with lived and living experience at the table can add kind of context, like something that might appear to folks as an issue around non-adherence. All of a sudden, by involving people with lived experience, they might actually point out, I don't think it is. Like, I think it could be about a transportation barrier, or it could be around stigma that's associated with the issue, or I think there's something else going on here. And so just having those different perspectives around the table when you're thinking about what it means and giving that context is amazing.
Okay, I'm going to go to our next scenario. I'm just conscious of time and making sure we leave enough
Right.
time for people, but I think we can at least get through another scenario. So Carolyn, you're on for this one.
Oh, so a health systems, a department has finalized a new clinic schedule, and now they want to engage patients and family partners to ensure buy-in. So again, what Sarah was saying around thinking about What are we trying to achieve? I know there's one question that would come up right away when I see this scenario. Um, I'm wondering if anyone wants to share in the chat box what question they would have if they were presented with this. I'll give everyone a second. I can definitely, I think I'll give everyone the hint. The first thing to me that would come up is has this decision already been made? Can patient and family partners inform? Is there flexibility? Is there any changes that patient and family partners could actually inform around this? Or are we really starting to move towards implementation? And are we really thinking about engaging folks and how do we implement this versus engaging them just around, say, the clinical schedule to get their buy-in, right? And so we're moving towards communications, but also there might be an aspect of how to engage at that implementation phase. Of course, always the biggest recommendation we have is engage early in the process. So even when you start thinking about restructure, doing different changes, it's better to get folks on board at the beginning, and to really have them inform decision making from the start. But yeah, if you we want to try to avoid engagement if the decision has already been made and there's not much of an ability to have a dialogue and to do some shared decision making.
Carolyn, you have some participation in the chat, in the
Oh,
Q&A.
yes.
I know it's hard to see when you're presenting. One person asked, can change still occur by engaging if the service is finalized? Another person
Yes.
said, is the schedule finalized?
Yeah.
Another person asked, who is involved in the redesign? Someone said, think solution oriented first.
Right.
And then someone asked, what is meant by buy-in?
Yeah. So yeah, I think those are really good points. So thinking about is there the ability to actually inform decision making, or are we just wanting to folks to check off and say, yep, okay. And that would be kind of buy-in, right? We just want to make sure everyone's like, okay, that sounds great. Um, then it's really not going to be meaningful engagement. So you really want to know if there's opportunities to still inform decision making.
Right. And when I hear buy-in, I think that this sounds a lot more like what this department is asking for as a communication strategy at this point.
Yes.
And so really what they're trying to do is we say we have a change and we know that in order to make a change successful, we need to communicate with people about the change and and the public and patients are some of our important stakeholders to communicate with. So again, a little bit of a misunderstanding about engagement versus communication, because at this point, like most people have said, and what we've seen, we've already finalized this new clinic schedule. So there may be opportunities for engagement at different points, but right now you're talking about communicating, it sounds like in this scenario. All right, we do have another one. And Carolyn, I don't know if you want
Mhm.
to run through that one or go through some of the other slides or quickly run through this. We just have a couple of reflection slides after this.
Oh, right, right,
Tie
right.
together slides. Yeah.
So maybe just quickly for this one. So if folks, if you had maybe a program or initiative that came saying we have low participation from equity seeking communities, thinking about what would you do. A lot of times that's really getting into the why and wanting to better understand. So that might mean engaging and building trust and relationship, and if they have some data around, we have this low participation rate and we're not quite understanding, that's when you can bring community members in and to really help you interpret that data and come up with solutions on ways to improve the service.
That's great.
And then again, I think these are reminders of common pitfalls. So using surveys when dialogue is needed. So really thinking about which one is needed, treating engagement as data extraction. Remember, we want that two-way dialogue going on and shared decision making. Expecting engagement to be kind of samples like representative, but rather we're looking at inclusive and diverse. And then interpreting metrics without engagement input. And I think the key takeaways, of course, if the question is what matters, you're likely going to use engagement. If it's, did this change work? You might be using evaluation that could include surveys. If it's how are we performing compared to others, it might be it will be standardized measures. And then what's going on here? Again, survey or signal detection. And here's some reflection questions for folks, is really thinking about where do you see confusion in your work? Where could engagement better inform measurement? And then what support would help you use both effectively?
So I think we're going to open it up now
Yeah.
for discussion. I just can't find my mouse. There we go.
It looks like we got lots in the chat.
There's lots of questions. The question of any recommended reading materials, books, or well-written articles. There are resources on the CHI website, and Carolyn has compiled a whole list of good articles and readings that could be found under resources at the CHI website.
And then Sarah, I think we've got some good ones on patient-reported measurement.
We do. Yeah, we have some resources there.
One question is wondering how PREMs and PROMs are currently being used or actioned in Manitoba, specifically at a health system level.
Yeah, that's a great question. And you're right. We could do another whole presentation. I didn't want to spend too much time on that. Currently, well, actually on the CHI website, we do have a database, if you will, or a registry of all the routinely collected PROMs and PREMs in the healthcare system. Typically, I'm just trying to go back to that question so I can see it. What we're finding is there's a lot more patient-reported outcome measures being routinely collected in systems. And of course, Cancer Care does a really great and rigorous job of that. There's only 2 instances, although we're trying to increase this. There are only 2 instances where we're using routinely collected experience measures. Cancer Care, again, does that. And then we do have this Canadian Patient Experience Survey for inpatient care only, so people who have undergone an overnight stay in a Manitoba hospital. We've just recently modernized this approach, so we no longer have this cumbersome mail out, but we do this electronically. So every patient who provides an email at registration and has had an overnight stay in a Manitoba hospital will receive this survey. And I'm going to answer another question in this question because I think Angelica makes a really good point here of saying that in systems that collect PREMs, it's sometimes you feel like you're doing a lot of this collection, but there's not a lot of change. The change seems to be the difficult part. So you bring up a very good point. We do in Manitoba, we have been collecting an experience survey for a long time, this one since 2014. And what we have set up a sort of a working group with input from all of the regions and specifically the quality teams, so that the data can be used back at the quality team level to make improvements and changes. Now we are going through a bit of a blip right now as we moved away from the mail out into the electronic electronic process, we kind of have a dip in volume just because we don't have a lot of emails on file, and that's the only way we can communicate with patients right now with this survey. So we just need to collect a little bit more data before we can really go on to making change. But we have it's not really an oversight committee, but a committee that gets together on a regular basis to take a look at the data and to talk about how we're using the data. And a part of that accountability is also accreditation. So we really need to show that we are asking patients, and if we are asking patients if we're doing well or how we're doing and what we can do to improve, we sure as heck have to be showing that we're using that data. And so we're very motivated to do that, to close that loop. And some of us are doing that a little bit better than others, and that has to do sometimes with just the volume of survey responses we have at this time.
Thank you, Sarah. There are so many questions. Um, there's a lot of questions about relationship building. One person says, as a novice student researcher, do you have advice on integrating levels of patient engagement and building relationships when facing resource and time constraints in the program? In my program, someone says you have to start building the trust with unrepresented groups, communities long before a survey. And someone says quality of participation is more important than quantity.
Right. I think the question around student researcher, absolutely understand. I'm actually a student in my other side of things, so I completely understand around building those relationships and how it does take time, and it of course is competing against your own deadlines with your committees and your supervisors. It's always wonderful when you find supervisors who understand that it may take a little bit longer to do that engagement. Sometimes really good things to do, I think, as a student, when you are thinking about a topic at the very, very early stages and you haven't necessarily quite refined your question yet, is really connecting with different community organizations and having a conversation with groups around, well, what are your priorities? And here's what I'm looking at right now. Maybe there's an area of connection here. And what I think we always laugh is it's a lot of sometimes going for coffee or having tea with folks and sitting down with folks. Sometimes a community organization might say, hey, come and present to our board of directors about what you're thinking about, and maybe we can find commonality. I mean, the most wonderful thing is if you have an opportunity to have conversations with community organizations and they actually identify a priority area that you can run with for your research, and then you can work together in co-design. But I think one of the big things with engagement in health research and understanding as a student where you're at and some of the time constraints around that is even just thinking about one decision throughout. So perhaps you can't have people with lived and living experience inform every single decision along your research process, but maybe there's opportunities at the design phase, or maybe there's a little bit of an opportunity at the interpretation, or even at the end of grant, like the knowledge translation phase. So really thinking about whether there might be an opportunity to have an end of grant knowledge translation, like a workshop at the end to share your findings and come up with ideas around knowledge translation materials. And then maybe next time they might actually give you some amazing suggestions for your next research project. So priorities along there. So just thinking about ways that you can integrate folks in decisions along the way, and understanding your scope. Oh, one of the great things is if you are a researcher in Manitoba, the Center for Healthcare Innovation has something called a PrEP Award, which will be launched in the spring. And that's a little pot of funding that can help you engage people with lived and living experience at the very, very early stages of your research process. So before you've even really laid out and designed your process. It's a pot of money so that you can compensate people with lived experience to come around the table and have some conversations around what priorities are important to them and how you might be able to co-design a project together.
Sarah, there's a question about equity.
Oh, I
When
see this question from Katie. Is this the
Yes,
here?
yes.
Okay,
Um,
great. Yeah, Katie, you're saying when collecting data with surveys that are emailed, are you concerned about excluding people without access to email? I wonder if this will exclude people with low income and people who live remote. You are absolutely correct. And yes, this concerns me and our team all of the time. And we continue to explore ways to address that. Oh, we have another prom-prem question that just came up.
how long would it typically take to conduct the research if a pre-validated questionnaire in the relevant subdiscipline of healthcare is unavailable?
Oh.
Um, okay, yeah. That one is a little bit of a nuanced answer, I think, depending that I think that not having the data that you need from our healthcare system to run your research project is an incredibly common issue, let alone it being a prom or a prem. It could take you a long, long, long time. Accessing data for research is challenging across the board. So I can't really answer that without getting into the nuance of a project, but you would have to get that data yourself, I guess. Yeah. Okay, there's doesn't seem to be any other
Y-
direct ones.
Yes, and it's perfect because we are just about running out of time. It's 1 o'clock. So I would like to thank Carolyn and Sarah for spending their lunch hour talking to us about some of the differences um, between their roles and the research, the proms and prems, and the patient engagement. Um, we have all learned so much, and thank you to everyone who has participated by answering some of the questions that Carolyn and Sarah have asked, and by your very engaged and meaningful questions that have shaped the conversation just now. You will receive a follow-up email with further information on how to access the slides and recording. We also welcome feedback for the session. When this session is over, you will be prompted to complete a short survey. We would also like to invite you to join us for March's Pell on Tuesday, March 10th at 12 o'clock Central Time with Dr. Amy Fryer, entitled Public Engagement and Data Equity, Approaching Inclusion in Administrative Data Studies. And thank you again for taking the time to join us. We hope that you are walking away encouraged to further explore the possibilities of patient engagement and proms and proms in your work. So thank you to everyone.
Thanks.
Thanks, everyone.